guys. All right. You guys good to start? Cool. All right, so let's go through these questions. All right, first one. We have a 34-year-old female. She's G3P2, 37 weeks gestation, coming in with diffuse abdominal pain and vaginal bleeding. She says before her symptoms started, she had contractions about every 6 minutes, which abruptly stopped. On exam, she's hypotensive. Her heart rate's 122. Respiratory rate is 25, and she's afebrile. When you look at her, she's pale and diaphoretic, and she has gross vaginal bleeding. The abdomen is tender, and there's no gravid uterus on palpation. What do you guys think this is? Who thinks it's, what'd you say? What? Okay, who thinks it's A? No, great. Who thinks it's B? Okay. What about C? And D, vasa previa? No. Okay. Yeah, so the answer is uterine rupture. Uterine rupture is a life-threatening complication of labor for both mom and baby. It's commonly due to in patients that had previously had a C-section and then they're given a trial of labor. So previous rupture is also a risk factor. And then induction and labor in general, obviously, is a risk factor. So clinically, if you have the mom hooked up to tachometer, you'll be able to see some fetal heart rate abnormalities, usually bradycardia. But clinically, the patient will complain of sudden abdominal pain, vaginal bleeding, lack of contractions. There'll be loss of station of the fetus, and you might be able to palpate fetal parts. And the patients can become hemodynamically unstable pretty quickly, so manage your ABCs and call GYN. Okay, next. So we have a 28-year-old female. She's brought into the ED after a home birth. On vital, she has a BP of 190/112. Heart rate's 101. Respiratory rate is 20, and she's satting 98. She denies any vaginal bleeding or abdominal pain. 10 minutes after arrival, the patient starts seizing. What is the most appropriate next step? Who thinks it's A? Who thinks it's B? Administer lorazepam followed by phosphonatoin. Who wants to give MAG? Yeah. And who wants to cry? It's fine. We love that for us. Okay. So yeah, the answer is administer MAG. So it's what we just spoke about going over the questions. So eclampsia is preeclampsia plus seizures, and this can happen after 20 weeks of gestation or anywhere between 2 to 6 weeks postpartum. And magnesium sulfate is the first line. It's contraindicated in people with myasthenia gravis because it blocks acetylcholine release. So it can precipitate a severe crisis. You also don't want to give it to people who have pulmonary edema. So the initial dose is 4 to 6 grams IV given over 20 to 30 minutes. And then you would start an infusion for 2 grams per hour for 24 hours. If the patient has renal insufficiency, I guess, like Dr. Student was saying, you may not want to give MAG at all. But what I read is that you can decrease the initial dose to 2 grams. And if the patient has recurrent seizures or if magnesium is contraindicated, you can do Ativan or Valium, and then manage the hypertension with labetalol, hydralazine, or nifedipine. Okay. So this is a two-parter. So after you treated her, you go to reevaluate her, and her blood pressure is now 130/78, but you notice she has respiratory depression and diminished reflexes in all extremities. What do you do next? Yeah, wait, what'd you say? Okay, who says B? Who says, okay, sorry, I said the answer, it's B. We already went over it, but yeah, so the answer is you wanna give calcium to essentially reverse the magnesium. So hypermagnesemia is something that we have to worry about. Usually, I don't know if when you guys were on labor and delivery, they had to do mag checks. That's what they had me doing all night. So one of the first things that goes is actually the patellar tendon reflex. So when you go to reevaluate your patients, check the reflexes, see the respiratory rate, you can have them on N-Tidal. And if you see any of these signs, you stop infusion and give calcium to reverse. Obviously, if they become hypotensive, you can give crystalloid, and if they show signs of pulmonary edema, you can give loop diuretics. Okay, next, we have a 21-year-old female at 40 weeks gestation coming into the ED in active labor. On exam, the fetal head is impacted against the perineum. What is the most appropriate next step? So what is that sign? It's a turtle sign, yeah. Okay, so who wants to do A, the Zavanelli maneuver? Do you guys know what that maneuver is? All right, so it's honestly where you push the presenting fetal part back up so that the patient can go to C-section. Sorry for the hand motion. Does anybody want to attempt to deliver the posterior arm? Who wants to do fundal pressure with the next contraction? And who wants to do McRoberts? Oh, the answer's already there. So yeah, so you're gonna do the McRoberts maneuver. We already spoke about it. It's when you flex the thighs into the abdomen and then provide suprapubic pressure. And obviously call GYN. Okay. So UPreg negative 25-year-old female presents with abdominal pain and vaginal discharge. Pelvic exam is notable for CMT and yellow discharge and right adnexal tenderness. On transvaginal ultrasound, there's a 5-centimeter mass adjacent to the right ovary. What is the most appropriate treatment? Who wants to do vancomycin? All right, what about cefoxitin and doxy? Okay, ceftriaxone and azithromycin, and flagyl. Okay, yeah. So you're gonna do cefoxitin and doxy. So this is a TOA. It's a complication of PID, and it's an indication for inpatient IV antibiotic treatment. The majority of cases are due to gonorrhea and chlamydia. So as we previously spoke, usually there'll be unilateral adnexal tenderness. There might be a mass that you can palpate. Patients may have fever. And then the treatment for this is usually a 2nd-generation cephalosporin plus doxy, or you can do the ceftriaxone, doxymetronidazole, or clinza and gem. 30-year-old female is brought in after home birth with heavy vaginal bleeding. Symptoms started after delivery of placenta, and on exam, she's tachy to 117 with active vaginal bleeding. What's the first thing you want to do? Who wants to give oxytocin? Bimanual uterine massage. Administer normal saline or give misoprostol. Okay, you guys got it. It's a bimanual uterine massage. So this is postpartum hemorrhage. And in this case, it's most likely due to uterine atony, which is the most common cause of it. So it's defined as blood loss greater than 1,000 milliliters or bleeding with signs and symptoms of hypovolemia within the first 24 hours after birth. And it could be either C-section or vaginal birth. Most commonly uterine atony, which on exam would feel like a soft, boggy mass on a palpation. And the first line is bimanual massage, and then you can also give oxytocin after, which would cause rhythmic contractions of the myometrium to kind of compress the spiral arteries. You can also give misoprostol, but oxytocin is typically preferred due to its greater effectiveness and less side effects. Yeah. Mm-hmm. I mean, you would probably do both, but like one of the first things you do is put your hands on the patient, right? And do a fundal massage, I would assume. Because I don't think PIT's going to be there like right away. But yeah, no, you would give both. Okay, so you have a 24-year-old female G1 P0 at 12 weeks gestation, presenting with nausea and vomiting. She hasn't been able to tolerate PO for over 1 week. On exam, she has a blood pressure of 185/110. Heart rate of 101, respiratory rate of 20, and statin 96. The uterus is palpable at the level of the umbilicus. What is the definitive treatment? So what do you guys think this is? Does anyone? Yeah, only pregnancy. So would you give Zofran and fluids? Would you do laparoscopy? DNC? Or antihypertensives? Okay, yeah. So this is a molar pregnancy, which falls under gestational trophoblastic disease. Signs of this are a very high beta HCG. Patients can have vaginal bleeding or pelvic pressure and pain. Uterine size is usually greater than gestational age. They can present with hyperemesis and can have a preeclampsia greater than 20 weeks gestation. So obviously, you know, we would consult GYN for this. There's a risk of this turning into choriocarcinoma. So D&C is pretty important for these patients. Okay. 35-year-old female, she has a history of high 5 presenting with vaginal bleeding and abdominal pain. Vitals are within normal limits. Labs are notable for a beta of 5,460. There's a gestational and yolk sac seen in the right adnexa on transvaginal sono. What is the most appropriate management? Who wants to send this patient for a laparotomy? What about methotrexate? Okay, laparoscopy. Yep, and then observation. No one's gonna observe. Okay, so yeah, the reason it would be laparoscopy is what we touched upon in the questions is contraindications to methotrexate. So there's absolute contraindications and then there's relative contraindications. So I think at least the ones that I was more familiar with were the relative contraindications. So if there's cardiac activity, if the beta is greater than 5,000, if the ectopic pregnancy is greater than 4 centimeters, the patient's not reliable to follow up, or refusal to accept blood products. But as far as absolute contraindications, it's probably not a good idea if there's an intrauterine pregnancy to give methotrexate. But if there's evidence of immunodeficiency, severe anemia, pulmonary disease, peptic ulcer, and you know, the rest of this table. And then laparoscopy would be appropriate for this patient because she was stable. Laparotomy is typically for unstable patients. Okay. So a 37-year-old female G2P1 presents to the ED in active labor. On pelvic exam, you palpate a pulsatile umbilical cord. What do you do next? Who wants to go ahead with the vaginal delivery? Okay, what about the Gaskin maneuver? Do you guys know what the Gaskin maneuver is? That's the one where you put the patient on all fours. Kind of, essentially, like in the case of shoulder dystocia, you put the patient on all fours and then try to retract the head that way. Elevate the presenting fetal part and keep the hands inside the vagina. And then you can cry again at this point if you want. Yeah, so you guys know it. It's elevating the presenting fetal part and keeping the hand inside the vagina. Not forever, just until the patient gets to the OR. So this is the case of uterine cord prolapse, which is an obstetric emergency. And patients need emergency C-section. There's a high likelihood of exsanguination of both the mother and the fetus if they go through with vaginal delivery. So you want to keep the hand inside the vagina in order to essentially prevent cord compression and then get these patients to an OR right away.
You can also put them in a Trump.
Right. Thanks, Dr. G. Okay, and then 17-year-old female, 33-week gestation, comes into CCT after an MVA. On exam, she's got a heart rate of 110. Her BP is 90/54 with a respiratory rate of 20 and satting 98. She's minimally responsive, but lungs are clear. There's a gravid uterus and no vaginal bleeding. What is one of the very first things you can do to try and improve this patient's BP? Yeah, so who wants to administer MTP? What about a bolus? Who wants to do C? Okay, yeah, and norepi. So the answer is C. Usually women in the 3rd trimester of pregnancy can have mechanical compression of the IVC with the gravid uterus. So one thing that you can immediately do while you're kind of going through your initial evaluation in ABCs is to turn the patient to the left to try and push the uterus off the IVC and hopefully increase venous return. Okay, thank you.